So welcome back to Hot Flashes and Cool Topics. Today we have a very important conversation with a wonderful guest, Dr. Carol Kuhle, who not only risked life and limb to be at our menopause event back in October, but it is also section head of the Menopause and Women's Sexual Health Clinic at Mayo in Minnesota. Welcome to the show, Dr. Kuhle.
Thank you. So nice to see you again.
Yes.
Such a great
Nice
chat.
to see you too. Really great to see you after hear what you had to go through to get there and get back. So
Yeah.
Oh
we
my
are thrilled
gosh.
to see you.
That's
Yes.
what travel is. So,
Yes.
no problem at all. No problem at all. Yeah.
It was so wonderful at the event to see women get their questions answered and feel like a part of a community, because your expertise is so invaluable to our community. And we thought a good way to start this conversation would be about what women should be thinking about when they walk into their doctor's office, because like you said, sometimes it's referred by your insurance, you don't necessarily know the person. So can we start with what do you suggest women, should they get prepared for a doctor's appointment to talk about menopause?
Right. I mean, I think optimally, if they can find a physician who is certified in menopause, that's really helpful because they're on the same page right away. So the North American Menopause Society has a website for patients where there are physicians in their area that are certified in menopause. So if that is the specific question they're having and they can find someone like that, that would be perfect. If they cannot, then I think when they meet with a physician that they're very clear about, these are the symptoms that I'm having. I'm not sleeping. I have cognitive blunting, because these are the things we hear from our patients. I'm having hot flashes all day, on and off. Sometimes they're worse than others. And then looking at, if they're having sexual health issues, are they having vaginal dryness? So hot flashes, sleep, cognitive blunting, vaginal dryness, those are kind of the premier questions that kind of pop up right away when women are going through menopause. The issue is clarifying, is this menopause or not, or is this something else? So understanding that they're in this age range, usually 45 through 55 is kind of the time where we see women go through this transition. And are they a candidate for hormone therapy? Am I a candidate for treatment for hormone therapy? The questions that will be important is, we assess women for breast cancer risk, not that they can't have hormone therapy if there's a family history, but we clarify how much of a family history. So understanding their own family history for breast cancer and for cardiovascular disease is really important, because those are the questions that we need clarity in when we're saying you are average risk. So when we're saying you're a candidate for hormone therapy, we're saying you're symptomatic, you're average risk, meaning that there's not a big history for very early cardiovascular disease in the family or breast cancer. And what do I mean by risk for breast cancer? We define women who have first or second degree relatives that were young when they had breast cancer. We define male breast cancer. We define breast cancer in both breasts. So those are risks that kind of pop up and say, where are you? Do you need, other management? But most women, when you look at that Women's Health Initiative trial, that's what kind of, upended everything in hormone therapy. And we're all still struggling with it because, the media didn't help us. They were kind of maximizing the negative of it. But we've had some experience with it now, which is really nice. So if you look at who was studied in that group, there were 150,000 women. That's a lot of women.
Wow.
You're not going to see another trial like that. So those women were randomized to hormone therapy or not. Okay. Some of them got estrogen alone. Some of them got estrogen and progesterone. And then they looked at, okay, these women did not have a high risk for breast cancer, did not have a high risk for early cardiovascular disease. And so they were safe for hormone therapy. Now, those women have been followed out now for 20 years. And so it's been very reassuring because the women who got hormone therapy for 5 years, followed out 20 years, actually had decreased what we call all-cause mortality, meaning that they died less from everything compared to the women who did not get the hormone therapy.
Wow.
So that was really, really an important finding. And we talk to women about, which bucket are you in? Are you in the bucket where you're average risk? Then you're going to benefit from hormone therapy because it does help with those hot flashes. It does help with mood. It does help with sleep. It does help with libido because you're feeling better. Then we look at what about those women who are under 45? That's a whole nother group. And that's really important. It was something that I tried to drive home when we were meeting because that's often missed. Sometimes physicians confusingly take that bucket and put it in the other bucket with older women. And that bucket is really, really important because if they don't get hormone therapy, they're going to have trouble as they get older. They're going to have a higher risk of breast cancer, of heart disease, of osteoporosis. So that's really important for women to know that if you're young, you're under 45, and clearly if you're under 40, you actually need hormone therapy unless there's some reason you shouldn't have it, like breast cancer.
You were talking about cardiovascular risk. What are some of the cardiovascular issues that happen that women should be aware of?
So one of the things that was confusing about that trial is that they said, oh, there's an increased risk for stroke in women who got the hormone therapy. But it was women who were in their 60s who had never been on hormone therapy. So the thing that we discuss, and you'll see a lot in our literature, is about the timing hypothesis. It's like, when do we give hormone therapy? When is it beneficial? When is it safe? When is it not? And so if we look at women at age 60 or older, they may have already developed some changes in their coronary arteries. And that's what put them at risk for a stroke. Okay. It was a small bump, but it was there. And it said to us, you don't start hormone therapy in somebody who's over 60. Okay. So we're very careful, and so the rule is around your menopause, within 10 years of your menopause, average risk, those are the women that we give hormone therapy to that are symptomatic. Okay. Because it also protects your bone. And now, we say to women, if you are losing bone, we see at menopause that there's a precipitous drop in bone. And we want to catch that. And our endocrinologists love us when we put women on hormone therapy because they know we're protecting their bone. So that is not a first indication, but it's a secondary indication. And if a woman has gone through menopause and has not been treated, and then we see them in the clinic and it's been a year or so, we'll do a bone mineral density because we're like, we want to know where your bones sit. And if we see that they've had a drop in their bone mineral density, that is a reason for them to be on hormone therapy.
Well, you just answered my question there. Because my next question was, obviously we used our own personal experience. As someone who just hit my 12 months of no period in November, yay. I didn't really struggle with the hot flashes like a lot of women did, but I do have osteoporosis.
Oh.
So, and I was diagnosed with osteopenia, but then I was told that it's really osteoporosis. And
Okay.
my levels have remained the same over the last 2 years, but how do I weigh whether it's worth? Like, what would a woman say? Okay, I really don't have some of the other symptoms, but I am concerned about my osteoporosis.
Yeah. So hormone therapy is not a treatment for osteoporosis. That needs an endocrinologist or a rheumatologist to treat you with alendronate, or depending on whether it's vertebral or whether it's hips. Okay.
Right.
So that's not we would not give you hormone therapy to treat your osteoporosis. We clearly want you to get treatment for your osteoporosis, however, because
Right.
fracture risk, I'm a geriatrician by training. And what I know is as we get older, we want women to be able to function well as they age. That first hip fracture, downhill. They've even demonstrated that in older women who fall and have hip fractures, there's a high risk of death within the next year.
Mhm.
which
Yeah,
is
we've
such a
talked
scary.
to the lady with
Claire
the
Gill.
yes, with the Osteoporosis Society, and she was telling us that. And
Well,
Yeah.
and I think a
yeah,
lot of women think, well, I didn't get the hot flashes, so I don't really need to go on hormone replacement, even though if, you know, might have some vaginal atrophy or something. It's so hard for women. What kind of red flags do you see when a woman comes in and said, well, I didn't have the hot flashes, but
Yeah, yeah. And the but is what's happening to your bone. That's the but. And that's why we do the bone mineral density, because, you know, there's this group of women that are like, I want my hormones, don't ever take my hormones away. And then there's a group of don't ever give me hormones, I'm petrified, kind of thing. And so you just have to put objectively the information out there and let them decide, because it is their decision. It's not me telling them what to do. It's to say, this is how we counsel you and think about this. I worry if you have bone loss that down the road, you would have a fracture. So, it's a very individual conversation with women. And it's not just about all the data. It's about, what they wanted. And it truly is shared decision making. Truly.
mhm. Yeah, you were talking about vaginal dryness and sexual health as well. And I know that that is something that so many women that go through
Mhm.
menopause
Right.
have issues
and are
with that.
embarrassed to talk
And they're
about it.
embarrassed to talk about it. And I don't think it's been really brought up that
Yes.
they just thought it was something personal wrong with them. Could
Yeah.
that be something when they come in and talk to you? Maybe they're
Yes.
not having hot flashes,
Right.
but
Right.
they're having that.
Yes.
Is that something that would have
Yes.
hormone therapy?
So we talk about, we look at the whole thing. If they're having libido issues that's a very complex conversation. So we have different consultation types, and one of them is sexual health. So they just come in to talk about their vaginal dryness, their pain with sex, and libido. So when we talk about libido in particular, we talk about, what's happening when they're having sexual activity. Do they feel aroused? Do they feel, are they lubricating? Are they able to have orgasm or not? What's happening in the relationships? And if everything looks like it's functioning okay, there still can be reasons why their libido is low. And certainly hormones is one of those reasons. We don't, let me put it this way. Then we kind of go through, all the physiologic things. We look at, did they have cancer? Is there something neurologic going on? How's their sleep? That's huge, because then maybe it is about vasomotor symptoms, and it is about, they're waking up in the middle of the night, they're having hot flashes, so that insomnia piece becomes a really important piece. Are they tired for other reasons? And then we look at, okay, so is there a mood issue here? Sometimes hormones can help with the mood issue. We don't treat depression with estrogen, but women will find that their well-being is improved on hormone therapy. We look at, what's your alcohol use? That's huge, because we look at all those triggers for hot flashes, and, alcohol can be one. We look at, their past. Has there been sexual abuse or sexual trauma? And what's going on with your partner? Because at the end of the day, that's really important. If you don't like your partner, you don't have good intimacy outside the bedroom, then maybe nothing's going to happen inside the bedroom. And certainly what we learned growing up, a lot of us have come into this sexual world with preordained thoughts about my sexual being. I should never have sex before marriage, all these things, and people, and just understanding the impact of that. So today, if we treat women with hormone therapy and they're menopausal, that there is an indication for testosterone. So if we look at go through everything else, and it looks like, yeah, this is hormonally related, with or without estrogen, we can offer testosterone. And we give it for 6 to 8 weeks. We have labs that we do, we monitor the levels and see how they do. And sometimes that's just a little bump because the ovary makes testosterone as well. So we get part of it from our adrenal gland, part of it from our ovary. And so when we go through menopause, it's not like there's this abrupt loss of testosterone, because we're still getting it from the adrenal gland, but it kind of drops off. Okay. Okay, so sometimes we'll go ahead and give them a trial of testosterone in the average risk woman again. And sometimes that's really beneficial.
And is it in a cream form or is it transdermal form?
Right. So there's lots
Yeah.
of conversations about how to do it. And I will
Mhm.
say here at Mayo, we, while we're very cautious about compounded medications because they're not regulated, you don't know what you're getting. We trust our pharmacy to create a cream. Because if you give women androgel, which is the male, androgel is what men get for testosterone. Women need 1/10 the dose. So you have to be very careful. And the one thing that we are very cautious about, in fact, we pretty much say we don't like the pellets, and we recommend not using the pellets. And the reason is once the pellet is in, you can't take it out. And so commonly estrogen and testosterone pellets are what are used. And we have seen testosterone levels be high for a year out. And we have seen patients with estrogen pellets in that get breast cancer. And it's not because of the pellets, but you have an estrogen positive breast cancer and you have an estrogen pellet sitting inside there circulating, it's feeding the tumor. So it's not FDA approved. I'm surprised the FDA hasn't really come down on it, but it's not recommended.
That is very important for our listeners to hear that
Yes,
as well.
I think
And
so.
And that
Mhm.
kind of leads me into the question of our doctors and their experience in this, because it seems like there is a small trend of doctors that are dealing specifically with menopause and midlife. But
Right.
for the average OBGYN, they don't get educated on this. What can women do besides looking at the NAMs? Because not everybody's going to find someone near them.
Right.
What I know you spoke about a study that at the time I think Bridget and I were talking about male interns and if they're educated on
A
menopause.
survey. Yeah, there
A
was a survey.
survey.
A male internist was,
Yeah.
was going to
Yeah,
do.
one of
Yeah.
our new consultants, they all have to come through here. So all the consultants, and we're internal medicine, we're not gynecology. We work with gynecology all the time, but our clinic is internal medicine. He was like, how much do men know about this? So we were talking about developing a survey. So when women come in, if their male partners are here with them, that we would survey them and see what their knowledge was. So he said he's working on it. It's over here. I'm like, all right, I'm here for you. Let's talk about it. Some, as we see what we can develop. But yeah, I think it would really be helpful for men to have a perspective about this as well, because they're either with their partners and oftentimes when women come in with the sexual health issues, sometimes the partners, around. And so when we have a sex therapist on our team. And so oftentimes, we'll see the patient, we'll figure out, all those domains and do a physical, see if there's atrophy, try and sort out. And then the two of them can see the sex therapist, whether it's their male partner or whatever, or even women who don't have a partner. If they have sexual health issues, they can still see the sex therapist, because that sometimes they're afraid to have a partner because they're having sexual health issues. So our team kind of works with it, and the people are having pain. Then we kind of sort out what, I tell women, why would you want to have sex if it hurts? Why would you want to? And I remember telling there was a tri-state public health conference up in Minneapolis. And I gave a talk and I said, if you can remember one thing, I think this should be on a billboard on the highway that says, for women, sex should not hurt.
Mhm. Yeah. And it's so interesting because women, if it does hurt, they don't know why. Like
Right.
what's happened? Why is it hurting? And
Right.
that's something, just through Colleen and I doing the show and just doing our research because we're focused on this,
Yeah.
found out the vaginal, like skin, it
Right.
thins. Is that correct? Yeah. And so I'm like, well, I never knew that until I really tried to find out
Mhm.
about just what women go through in menopause.
Right. And that's so easily fixed. And it does not increase your risk for breast cancer.
Yeah.
I mean, I treat women in their 80s with vaginal estrogen. because they start having bladder infections.
Mhm.
So it's not just about sexual health, it's also about your genital health, because the urethra where you pee out of is right there. It has estrogen receptors, and women will start having this gotta go, itchy feeling. Little estrogen goes a long way. In fact, I had the infectious disease department call me, and they were like, we're seeing all these women with bladder infections and we're not finding anything. Could this be menopausal? And I'm like, absolutely. And so there have been studies where women were having bladder infections and you treated them with topical estrogen, just little estrogen right there, and they went away.
That is
Wow.
amazing. And it's just it's not well known. Like actually I had UTI issues about a year and a half ago.
Yeah.
And exactly, just things to do to treat it. Now I'm like, oh my gosh, it was so simple.
Yeah.
And it's so hard to find that answer.
Yeah.
It was just like really digging and actually Colleen and I interviewing different people and
We
finding
get a
out,
lot
like,
of our questions
we
answered.
we do. I was like, well, I never knew that, and
Yeah.
how great that's available. And you brought up the vaginal estrogen, and I know that when you were at our event, you
Mhm.
talked about that as well. I think another person brought up a question, another person on the panel, about people that had breast cancer could take it, but I know that you said maybe not if they have active breast cancer. Is that
Right.
correct?
Yeah, I say we take an active pause is what we do. So if a woman is being treated, then we don't give it to them. So, but there are vaginal moisturizers. And so they are actually, there's been some head to head with vaginal moisturizers and estrogen, topical estrogen or estrogen tablet. And it was about the same, but we find that after 12 weeks of vaginal moisturizer, women are really improved. And so we always go there first.
Mhm.
And then we, again, we put them in buckets. When did you have your breast cancer? What type was it? What was your treatment? Are you on endocrine therapy? How bad is it? So there's a whole decision tree, so to speak, of how we approach women specifically. In fact, I'm giving a talk in Hawaii next month on sexual health and breast cancer patients. And so that's part of it is, how do we approach vaginal atrophy in women who have had breast cancer.
Mhm. Oh, that would be really. I hope your flight goes much better to Hawaii
Yes.
than it did.
I think being delayed in Hawaii is a little nicer than. What questions should women be prepared to ask? They walk into an OBGYN's office and that OBGYN has seen 3 pregnant women, some teenagers that are just about to start their cycles.
Yeah.
But what questions, if you had to pick like 1 or 2 questions that a woman who is in that 40 plus demographic should get
Yeah.
answers to, should be able
Right.
to ask and get answer. And if they don't get those answers, red flag, maybe find somebody else.
Yeah, I would ask if they're comfortable with treating patients with hormone therapy. I mean, that's a very direct question where are you with this? I mean, when they schedule their appointments, it's always interesting, because I was just meeting with our schedulers, how we make appointments and figure out who gets where. When you're scheduling an appointment, that appointment is very specific. This is about menopausal hormone therapy, or I'm having hot flashes, so that it's very clear right up front, that's what you're coming for. And then if they say, okay, yeah, we can schedule that. I mean, that's a clue to me that that they're comfortable with addressing that issue. I don't know what every provider out there, gynecology, family medicine, or internal medicine, knows about hormone therapy. But I think being clear right up front that that's why you're there, and then being armed with that information about, your cardiovascular risk, where are you in terms of what's your specific risk? Do you have high blood pressure? Do you have hyperlipidemia? Those are not reasons not to treat, but it gives you a snapshot of what your cardiovascular health is, what your breast cancer health is. So I think those are the 2 things. And then, of course, are you having some vaginal dryness? Because, I think most gynecologists would be very comfortable with vaginal estrogen at the least. Whether they're comfortable with hormone therapy is, hard to know. I hope that's helpful.
Oh,
No,
that is,
it is helpful
yeah.
because we get so many questions from listeners saying, "Oh, well, I had my 12 months of no period, so I guess it's too late for me to take hormone therapy," or they
No, not at all.
simply don't know
Yeah,
what to ask
right,
their
right.
doctors.
Yeah.
Mhm, mhm.
The thing that's really interesting too, that actually one of the times that you want to capture women is when they're going through their transition before they even hit that 12-month period, because that is a time when they can be very symptomatic, and they're just trying to get through it. But it's confusing because the ovaries don't just shut off. They're kind of on again, off again, on again, off again. And women will tell you, I had hot flashes and they kind of went away and I got my period. And it's because the ovary kicked back in. So they were feeling a little bit better. And during that time, that's when we see bone loss sometimes. We'll see these other things happen. And so capturing that group and putting them on hormone therapy can really be very helpful.
And that's another thing I think women don't realize. That's maybe the best time to go. I think that's
It is.
actually when I first went and
Yes.
asked
Yes.
a gynecologist about it. I still
Right.
wasn't completely finished with my
Right.
cycles, and
Yes.
she did not want to put me on hormones. She put me on Effexor
Ah,
initially, and it
okay.
really didn't help at all.
Yeah.
Yeah, and then I did go on hormone therapy.
Okay.
Um, yeah, and then it was like, "Ah," it was great,
I
yes.
get thank you notes all the time.
Oh, it was like, "Oh my gosh, game changer." It really was. And, you talked about, cancer, breast cancer survivors and
Yes.
survivorship, and you were talking about you're gonna give a talk with them
Yes.
about that.
Right.
What are some sexual issues that come up? Like, if they can't take a
Yeah.
hormone replacement,
Right.
what are some options for that?
Yes. Yeah. So there was a very nice study actually, that was just completed at Sloan Kettering. So I'm on a board with Sherry Goldfarb from Sloan Kettering, who's a medical oncologist who does breast, and they did do a study on flubanserin. So small study, but flubanserin is a medication that increases norepinephrine and dopamine in the brain. Okay, so those, when we think about sexual drive, it's not just the vagina, it's not just the vulva. There's also mechanisms in the brain that are drivers. So estrogen, testosterone are drivers in the brain, but norepinephrine and dopamine are also drivers in the brain. So this medication in particular, which is FDA approved for low libido, was done in breast cancer patients. And this was specifically breast cancer patients on tamoxifen. So that's the group that we know about. And so it didn't appear to have any adverse risks in the 24-week trial. And women responded to it. So that's one group that we'd say, okay, we feel pretty comfortable. There's some other medications that are out on the market. There's a shot that women can give themselves like 45 minutes prior to sexual activity that increases libido and seems to increase what they call sexually satisfying experience. So that's out there. It's not been tested in breast cancer patients, but it's not contraindicated either. Wellbutrin is a medication that increases dopamine, and sometimes that helps women with sexual health issues, especially women who are on what we call SSRI, so Prozac or paroxetine or any of those SSRIs. So the difference being, when you look at breast cancer patients specifically, which are the treatments that we would choose. So flubanserin might be one we would choose for patients that are on tamoxifen. Would we give it to other patients? I mean, it would have to be a shared decision making. We don't know everything about all these things, but we say, this is what we know. I don't think this will hurt you. It's something to consider.
That is really encouraging to hear. Because, yeah, I
Absolutely.
feel like so many women that face that, and so many women do face
Yeah.
breast cancer.
Yes. Yeah.
Yes, they just feel that there's nothing else out there
Yeah.
for them.
Right.
Yeah.
Yeah.
You're on obviously the cutting edge of all of this new information. Where do you see menopause going in the next couple of years as far as treatment and options for women?
Well, I would say that there's two places. There's, NAMS is the North American Menopause Society. There's lots of, publications all the time that are coming out, and what's really interesting about menopause and what we're really beginning to understand is what happens during a hot flash. Because we used to think it's just like a bad feeling, but it's not. There's concerns that there's something happening at the artery when somebody's having a hot flash. So we're beginning to understand the mechanism of hot flashes, and we're understanding, why does estrogen help, and where are there other medications that are non-hormonal that can then begin to help with the hot flash. Because in those women that can't take hormone therapy, how do we help them? And so there's medications on the that are now in the pipeline, let's say, that are pretty close to having those trials done that we hope will be FDA approved, that will really hit the mechanism and decrease the risk. Because, when they've done studies looking at the brain in women who have a lot of vasomotor symptoms, there's some what we call increase in white matter. So are there some permanent markers in the brain that women are having vascular changes in the brain because of their hot flashes?
Wow.
And so does that put them at risk? Is a hot flash actually a cardiovascular risk? Is that a red flag that there's something going on from a cardiovascular standpoint? So there's lots of studies going on looking at that, and publications that are coming out all the time that are helping guide us in terms of, let's look at this a little bit closer. And even the American Heart Association, we were really pleased about this, published a paper last year agreeing with it, that we really need to understand the timing hypothesis and when's the best time to treat a woman that is actually heart protective. So we don't give hormone therapy to protect the heart, but we're thinking it probably is, So lots of stuff going on. And so there's a big conference with the North American Menopause Society for providers to go to on an annual basis. ISWISH is another organization that looks primarily at sexual health. And so that's another place where providers can go and get educated about sexual health in females. And it's not just, through menopause, it's on a lot of different levels. So that's an excellent organization as well that has provider list that people who are active in that community.
What was the name of that one again? You said
ISWSH is ISSWSH, and it's the International Sexual Health something.
okay.
I'm sorry,
Okay.
I'm forgetting the whole
Yeah.
title.
She knows the letters. That's all
Yeah,
you need to
it's
know.
which-
Letters.
yeah,
You can
that's
put that in
fascinating.
and it'll come up.
You'll find
It'll
it.
come up.
That is,
sure.
And we'll
yeah.
have it in the show notes for everybody.
Yes.
Yeah,
Yeah.
because they have excellent webinars too, and more meeting than once a year on pelvic pain and sexual health from pelvic issues, and so it's also a great resource.
Thank you so much, Dr. Kuhle.
Yes,
We know you
thanks
probably
so
have
much.
patients waiting.
I
in the
know you
you.
have patience and patience, both different.
Right.
Yes. But yeah, that was just really hearing about all these studies is so encouraging, because as women, we often feel like we're not on the top of the
Right.
the
Right.
list.
Women's
And
health
so-
is at the bottom of the list.
and so it's really encouraging to hear about
Yeah,
these.
absolutely.
Yes. Yeah.
Thank you so much
Really.
for taking the time, not
Yeah,
only
thank you.
to risk life and limb to get to New York.
Us.
Luckily,
was-
this is by Zoom, so it's a safer
Yes.
bet. But
And yes, enjoy Hawaii when you go.
Yeah,
And,
well,
yes.
well,
thank you
Yeah.
so much for your
Thank you so
time.
much.
It's delightful to see you guys.